Okay, I think I'll go ahead and get started and hopefully a few more people trickle in. Thanks for joining to hear about diaphragm pacing and kind of what's new in this field. My name is Sabrina Drexel. I'm a general and gastrointestinal surgeon here in Portland, Oregon. And I was hoping to give this talk to kind of educate and bring awareness to the advances we made in diaphragm pacing and let people know specifically in the Northwest that I'm available for doing this type of procedure for patients that qualify. So I don't have any relevant disclosures. I've been an invited speaker in the past for Medtronic regarding complex abdominal wall hernia care, but that doesn't relate in any way to this talk. And I'm not, reimbursed by Synapse in any way in giving this talk. So my background is I was actually a general surgery resident here in Portland, Oregon at Oregon Health and Science University from 2014 to 2019. I did my fair share of trauma surgical rotations here. We have 2 level 1 trauma centers, both at Oregon Health and Science and at Legacy Emmanuel, and certainly saw some patients that could have qualified for diaphragm pacing. But I actually had never even heard of diaphragm pacing until I elected to go into minimally invasive surgery and performed a fellowship at University Hospitals in Cleveland over the last year from 2019 to 2020. And Dr. Anders happened to be one of my associate fellowship directors. And he is also the founder of Synapse Biomedical and the inventor of the diaphragm pacing system. So over the course of my fellowship year with him, I kind of became more interested in this research he's done and participated clinically in implanting about 35 patients with pacers. And he also had the opportunity to go to pacer clinic with his nurses who follow these patients closely. I got to see the EMGs they performed on patients and kind of see, how patients did well, everything from, how to reprogram the pacers to taking wires out when patients no longer needed it. So it was actually a really great experience to get to spend a whole year kind of interacting with the diaphragm pacing program that's there. That's, probably the most robust in the program since Dr. Anders is there and he's doing all sorts of research. But so after I was done with my year there, I was grateful to get a job back in the Pacific Northwest in Portland and started here at Northwest Minimally Invasive Surgery in August of last year. And I recognize that there's this need for, promoting diaphragm pacing specifically in the Pacific Northwest, and that there isn't anyone performing implants for patients or even evaluating patients. And I think the closest physician doing these are down in California. And so I definitely know of a couple patients on my trauma rotations that would have potentially benefited from diaphragm pacing and at least gotten off a ventilator faster or bypassed the need for a tracheostomy altogether potentially. So that's really my goal and my motivation for giving this talk is just trying to bring awareness to this technology that exists and has been shown to be efficacious for certain patient population. So kind of the background of diaphragm pacing, the idea of stimulating the phrenic nerve, which innervates the diaphragm, isn't new. It actually was explored back in the 1970s with a device called the Avery phrenic nerve pacer. And the goal was, again, typically in children that had ventilator-dependent needs, that they were trying to stimulate the phrenic nerve to contract the diaphragm and augment the ventilation for these people. However, back in the day, this was an open thoracic surgery, and they had to actually isolate the phrenic nerves, and they tried putting the pacers up high on the phrenic nerve, kind of in the thoracic inlet, and kind of trying to isolate the phrenic nerve in that area could actually potentially lead to injury, so that if the nerve was injured more distally, that even though you got a pacer placed, it wouldn't actually work. And so I think this fell out of favor kind of in the 80s, and there's certainly case reports of it being successful, but it wasn't kind of universally accepted as a great option for these patients that were chronically ventilated. And so Dr. Anders started doing research into, how can we stimulate the diaphragm in the 90s, and I was really interested in the diaphragm because it's kind of an often neglected organ, I feel like. And he actually did a ton of research in the 90s and actually did his first implant for spinal cord injury patients in January of 2000. He then went on to implant patients with ALS and even pediatric spinal cord injury patients, and now has over 20 years of experience doing implants. He has the FDA approval for this device, and it is a humanitarian device exemption just because spinal cord injury patients are rather rare, and it would be hard to get a ton of data to get full FDA approval. But there's been now, since kind of inception of this in the 2000, over 2,000 implants worldwide in over 25 different countries. So my goal is to kind of talk about how you place the pacer, who qualifies for a pacer, and then kind of go over some of the data for pacing. So it is, like I mentioned, a humanitarian use device, meaning that it has kind of special exemptions from federal law to get full FDA approval because it only benefits a small portion of patients. And it is only FDA approved specifically for spinal cord injury patients who are going to need the assistance of a mechanical ventilator. And really the whole goal is to get these patients off the ventilator for at least a few hours a day. And you'll kind of see in some of the patients I talk about later on how that kind of benefits their overall care and recovery. So again, how it works, rather than trying to stimulate the phrenic nerve up high in the chest like they tried in the 1970s, this actually stimulates the phrenic nerve at the motor endpoints on the diaphragm. And that stimulation of the phrenic nerve leads to contraction of the diaphragm and leads to respiration and ventilation. But these patients must have an intact phrenic nerve for this to work. Otherwise, there's no nerve to stimulate to actually conduct the electrical stimulation to the diaphragm. Again, we're implanting from the actual abdominal side rather than the chest side, and I'll show you in a moment how we do this in a minimally invasive approach. So it's a much less invasive surgery than in the past. This is kind of what the external box looks like on patients and kind of what the external site looks like of the wires that are placed, and this is the patient kit that they are sent home with. And I'll explain in a minute that they get 2 of these boxes and batteries and changing pads and get taught how to kind of take care of the device. So the external component is called the external pulse generator, or EPG, and it's a 4-channel device, and we place 4 electrodes in the diaphragm, 2 on the right side and 2 on the left side, and each electrode can be independently programmed and controlled. Now the patients can only really turn the device on or off. They don't actually change the settings themselves, and I'll show in a minute how we change those separately. But the nice part is that it's battery powered. They can either use just kind of regular size C alkaline batteries that last about 4 days at a time, or they can opt for a little bit more expensive lithium batteries, but those last for about 500 hours or about 20 days. Patients are shown how to change the batteries themselves, and there's a second internal battery in the device so that while they're changing the battery, the device doesn't turn off. But this leads to a lot of independence and freedom in terms of being at home managing the device and not being connected to an electrical outlet. So overall, why I use pacing. I'll go over the indications for specific patients in a minute, but overall, like I mentioned, these wires can be placed in a minimally invasive fashion. It leads to more negative pressure breathing, which is more natural than a positive pressure ventilation, because the only other option for many of these patients is being on a chronic ventilator. Again, quality of life of having this pacer in their pocket or in a belt that's hidden underneath their shirt is a lot easier than being connected to a ventilator. If or when they don't need the pacer any further, we can remove the wires in clinic. It doesn't require another operation to remove. And it's overall inexpensive and cost effective compared to a chronic ventilator. And again, their settings on the pacer can be titrated in outpatient fashion. So kind of the overall indications, the only FDA approved indication right now is for high spinal cord injury patients that are ventilator dependent. So that's usually going to be your cervical spine injury patients. And I'll go into some of that data in a minute. There are certainly off-label uses that I've seen and done with Dr. Anders with good results, including iatrogenic phrenic nerve injuries from prior cardiac surgery, idiopathic hemidiaphragm dysfunction or elevated hemidiaphragm seen on chest x-rays with associated respiratory insufficiency. And he's doing a lot more research now into ventilator-induced diaphragm dysfunction and how to kind of balance that with putting in potentially percutaneous or temporary pacing wires, which I'll kind of talk about at the end. But for the spinal cord injury patients, overall, we know that about 17,000 spinal cord injuries happen per year in the United States, and about half are at the cervical level. Of those, about 8,000 patients or so, about 60% will need a ventilator at discharge. And the ventilator is definitely the most common cause of morbidity and mortality in these patients because of the high chance of getting ventilator-associated pneumonia. And the ventilator is also very expensive to troubleshoot and maintain. So you can kind of see in this data from the National Spinal Cord Injury Center that the cost in the first year of a patient that's a high tetraplegia is over $1 million, and much of that comes from the associated cost of the ventilator, both in the hospital and whatever care facility they end up at. And we also know that these patients that are on a ventilator have a much decreased life expectancy compared to the average population, or even compared to patients that have a spinal cord injury that are not ventilator dependent. So for patients that survive the first 24 hours after a spinal cord injury, if they're paraplegic, they certainly have a decreased life expectancy, but compared to anyone that's on a ventilator, these patients fare off much worse. And that's, again, often associated because of pneumonias caused by being on a ventilator long term. And that's shown even for patients that survive 1 year post-injury, that they still have limited life expectancy compared to someone else that has spinal cord injury. Excuse me. My children decided to give me a cold this week, so I'm still getting over it. In terms of outpatient ventilatory care, patients have difficulty with tracheostomies. It requires a lot of secretion management and increased care overall. It can be difficult to have speech with a tracheostomy in place, and it limits mobility due to need for an electrical outlet with a short battery span. And again, like I showed, that overall patients that are on an outpatient ventilator have decreased survival. So in the spinal cord injury patients that might qualify for a diaphragm pacer, really the goal is to get them off the ventilator. Sometimes if patients can get implanted early enough, it can even bypass their need for a tracheostomy altogether, and especially in younger patients. If it's within 2 to 3 weeks of injury, then they don't have the scars associated with a tracheostomy on their neck. And we have data that shows that earlier implantation leads to better overall results for these patients. So who can make it to surgery? Definitely, you're going to want to assess overall patient's fitness for a laparoscopic procedure, their cardiopulmonary function and other medical comorbidities. In terms of a preoperative workup, definitely want a chest x-ray and an ABG, and want to be seeing that these patients do have CO2 retention, because again, the diaphragm pacer is really about improving ventilation, not necessarily oxygenation for these patients. And then for research purposes, is the diaphragm able to be stimulated? And we can see that with fluoroscopic tests where we have patients breathe in and out under special fluoroscopic x-rays to see if the diaphragm is moving or not. And then they can also conduct phrenic nerve studies to see if the phrenic nerve is intact preoperatively. I don't think my institution has access to phrenic nerve conduction studies, and it's really for research purposes, but certainly fluoroscopy can be helpful. But ultimately, I'll show you in a minute, taking them to the operating room, one of the steps is to see whether or not their diaphragm is stimulatable. So the operative procedure consists of 4-port laparoscopy. It takes about 2 hours or so to place the pacer, and it's basically 4 steps. The first is just establishing laparoscopic access and getting your ports in place. The second is mapping the diaphragm to find out where the phrenic nerve is most stimulated, and then implanting the electrodes and then routing the electrodes underneath the skin. So the electrodes are implanted by a flexible hollow bore needle on a laparoscopic delivery instrument. And they're small wires that go into the intramuscular portion of the diaphragm. And again, we place 2 on each side. These are some videos of actually mapping the diaphragm to see that it stimulates. So this is the left side of the diaphragm. This is the heart beating. And this is just one of our instruments that we connect an electrode to and make sure that the diaphragm is actually able to be stimulated. So you can see as we see contraction of the diaphragm. On this side, this is what we would consider a dead diaphragm, meaning that the phrenic nerve has been interrupted. So that even though we're trying to stimulate the diaphragm, we don't see any contraction. And here we're making sure that our stimulator is actually working by going down to the rectus muscle and contracting it. And you can see good muscle contraction there. This is the right side of the diaphragm. And again, you don't see any movement with stimulation. So that's someone that wouldn't qualify for implantation. Again, some of those preoperative tests like fluoroscopy can be helpful in identifying patients who might have a diaphragm that you can stimulate versus not, but it's not 100% effective. And the best way is just to take them to the operating room and perform this diaphragm mapping. If the patients have a diaphragm that stimulates, then we can implant them, and we try to place the electrodes at the kind of highest point of stimulation. So this is just an example of getting the electrodes into the intramuscular portion of the diaphragm. This is on the right side of the diaphragm. And again, we put 2 electrodes on each side, really just to make sure that if one breaks, we still have one that's working. And then this is a video of contraction of the diaphragm, and you can see how much force you can really get with those electrodes in place with a diaphragm that's stimulatable. After all 4 electrodes are in place, we bring them out through this epigastric port, and then we tunnel them under the skin in a subcutaneous fashion. So these are our tunnelers in place, and then we place 1 grounding wire also in the subcutaneous tissue, and then connect it to our grounding block. So this is the block that the electrodes are placed in, and this is the pad that connects to the patient's skin, and then the EPG plugs directly into here. And again, each electrode can be controlled individually, setting a different amplitude or different stimulus depending on patient's tolerance. The EPG is then programmed by the NeuRx clinical station, and again, this is what the staff of Synapse is trained to use to program the EPG. So the patients don't do any programming themselves. The goal is to set them at the highest setting with no discomfort. And again, each electrode can be programmed individually. So in patients that have a high spinal cord injury with no sensation, they can be programmed at a much higher setting than someone that might be getting an implant due to diaphragm dysfunction and have full sensation. They will probably have to start at a lower setting so that they don't have any discomfort from the stimulation. Post-operatively, we usually program them post-op day 1 once all the anesthetic has worn off to see what the patients can tolerate. They do have 2 EPGs per patient, and so they can always send one into the Synapse biomedical team to have them set higher settings on the box and have it sent back to them so that they can always switch off and always have one at home and one that's getting reprogrammed to slowly increase their tolerance over time. In terms of the immediate post-operative care for these patients, they usually have just a 23-hour overnight stay. We typically get an X-ray in the post-operative care unit to ensure that they don't have any retained capnothorax and just to get a baseline X-ray after implantation. We give them pain medications just as any other laparoscopic procedure, and they can tolerate a regular diet. And we let them resume their normal activities day 1. In terms of the pacer care afterwards, the patients can shower post-op day 1. This is kind of what it looks like, a dressing, and then this part is all changeable. We teach them how to change their dressings and how to change the batteries in the EPG, again, either using the alkaline or the lithium batteries. And then again, they can send in their extra EPG to titrate the settings once they go home. So why does this work, and what do we know about kind of diaphragm dysfunction from being on a mechanical ventilator? So this New England Journal of Medicine paper back in 2008 showed that the majority of patients spend most of their time on the ventilator actually trying to wean off the ventilator, and usually 40 to 60% of their time is spent weaning. The diaphragm muscle actually rapidly atrophies. It is converted from slow twitch muscle fibers to less functional fast twitch fibers within 24 hours of being on positive pressure ventilation. So we know that that positive pressure ventilation isn't good for the diaphragm muscles, and it can take a long time to try to recover strength. Just as like skeletal muscle, if you don't work it out, it can require, days and days or weeks of conditioning to try to get that muscle stronger again. Same thing with the diaphragm after disuse from being on a ventilator. So that's why, just like for muscle strength training for skeletal muscle, that we have to do diaphragm conditioning as well. And so this is the process of re-strengthening the diaphragm to get off mechanical ventilation and just be reliant on the pacer. It doesn't require any more monitoring than any other type of ventilator weaning, and it can take anywhere from a day or 2 to months or years if the patient's been on mechanical ventilation for a long time and has significant atrophy of the diaphragm. Oftentimes this process is influenced by, again, length of time they've been on ventilation as well as the age of the patient. Typically younger patients are going to recover much faster than older patients. There's 2 types of kind of weaning. There are pacing sessions with no ventilator attached, which we prefer, but then there's also pressure support weaning that they can do. In terms of traditional weaning, we'll figure out what their tidal volumes are, and the patient can kind of dictate the schedule of how often they want to do sessions. They can be anywhere from just a few minutes to several hours. We basically turn the ventilator off and turn the diaphragm pacer on. And then see how the patient does. We return the patient to the ventilator when they request, they feel short of breath or they're tired, their pulse oximetry drops, or their tidal volumes start to decrease. And the next session can be as early as 1 hour after stopping that last session. The pacer is the other option for weaning is the pressure support. The pacer is programmed and the ventilator is placed in pressure support mode. And so the diaphragm pacer is placed on, and then they're still on the ventilator in pressure support. And then hopefully you can decrease the amount of pressure support the patient has on until the mechanical ventilation can be removed altogether. This is a little bit more difficult to perform this type of conditioning just because the patient gets used to kind of the sensation of both devices going at the same time, and they may feel air hunger or some shortness of breath when one device is removed. Their tidal volumes can also get too large if they're not closely monitored. If the pacer is doing a lot of ventilation for them, then they can get some barotrauma and things from having too high of tidal volumes. And if the patient's at home to wean and don't have really experienced caregivers on, it can be a kind of barrier to trying to get off the mechanical ventilator. In terms of patients that are in the ICU for diaphragm pacing, it's kind of the same as if you do mechanical ventilation wean. You don't really need to change any of the parameters that you're monitoring. You're still assessing for patients' need for suctioning to end a weaning trial and put them back on the ventilator if they're feeling shortness of breath, and any other alarms. So in terms of the data behind diaphragm pacing, there's several papers that have been published, and again, over 2,000 patients that have had a pacer placed. So this is data out of Jacksonville, Florida, from a trauma group that started universally implanting any cervical spinal cord injury patient in 2011. So they did a retrospective study of center-matched cohort analysis of 40 patients that had diaphragm pacers placed for cervical spinal cord injuries versus 61 patients that were conventionally managed with a mechanical ventilator and tracheostomy. The overall mean time to getting a diaphragm pacer placed for these patients was 14 days. And their data showed that the diaphragm pacer patients had significant lower mortality rates than the mechanically ventilated patients, as well as a significantly lower hospital stay. And then for patients that developed a ventilator-associated pneumonia, the diaphragm pacer patients had significant shorter time on the ventilator, even if a pneumonia occurred. Their caveat was that, their matched cohort analysis, the mechanically ventilated patients were typically in an earlier time frame from about 2005 to 2011 until they started implanting for diaphragm pacers, so that there might have been some conflicting just improvement in overall critical care management that might have also improved their numbers in terms of mortality and length of stay with the diaphragm pacer patients. But overall, I think this is very convincing evidence that there's certainly no harm for these patients with getting a diaphragm pacer, and it may actually significantly benefit their overall hospital course. The same group then looked at their kind of actual respiratory mechanics with the diaphragm pacer, and they could actually visibly measure a significant increase in patients' spontaneous tidal volumes. And the median time to liberation off the ventilator after a diaphragm pacer placed was significantly shorter, from 10 days down from 29 days with mechanical ventilation and a tracheostomy. So that extra 20 days off a ventilator, as you can imagine, just really helps facilitate these patients' care in terms of rehabilitation and getting out of the hospital. Overall, there wasn't a change to liberation prior to the hospital discharge, meaning that mechanically ventilated patients also got off ventilators, overall at the same rate as diaphragm-paced patients, but at a much longer time frame. So in conclusion, they thought that diaphragm pacing produces significant improvements in spontaneous ventilation and reduces the time to getting off the ventilator. Again, this same group also looked at the cost, and diaphragm pacing did show that a significant decrease in acute care hospital costs by about $140,000 per patient. And again, those extra 20 days of not needing to be on a ventilator certainly contributes to that. And they also adjusted for, year of injury, injury severity scores, ages, sex, and race, and there was still this large cost benefit from putting a patient on diaphragm pacing over keeping them on mechanical ventilation with tracheostomy. Another study also showed that diaphragm pacing and spinal cord injury is not only successful in weaning them, but also bridging them to independent respiration, kind of similar to those prior studies. But this was a different group of patients. It was across 10 different sites in the US with 29 patients total. Overall, 22 of the 29 patients were able to get implanted, meaning that 7 of them had that denervated diaphragm at surgery where they couldn't get any contraction, and so they weren't able to be implanted. Overall, similar course of those 22 patients that were implanted, 16 weaned off at an average of 10 days. 2 had delayed weans that lasted more than 90 days. 3 had partial weans, meaning that they were on the pacer for part of the day, but ultimately needed the ventilator for at least 4 hours a day. And 1 patient withdrew care. So their study concluded that overall patients had significant improvements in overall survival, as well as quality of life compared to patients that didn't have a diaphragm pacer. And again, these pacers can be temporary, and when patients do recover their respiratory drive and function, the electrodes can simply be removed in clinic. So just an example of one patient, this is a 16-year-old who had a wrestling injury and had a high C-spine injury from C3 to C4 with a C4 fracture, and he had to undergo C4 to 5 fusion. He was initially breathing independently, but on post-operative day 2 and post-injury day 3, he required oral intubation for respiratory failure. He was intubated for 7 days and then extubated to non-invasive ventilation. However, several hours later, he was re-intubated and was found to have complete left lower lobe collapse on chest X-ray. And despite multiple attempts at weaning him off the ventilator, he wasn't able to be weaned. And so he was transferred to our institution at University Hospitals in Cleveland for diaphragm pacing. The implant was done on day 19 after injury and day 17 of being on the mechanical ventilator. He began pacing post-op day 1, and the vent was placed on pressure support, and he was actually extubated on post-op day 2. He did have some cough assistance for the next few hours after intubation to ensure that he was able to clear his secretions okay, but he was actually discharged to a spinal cord injury rehab center day 7 after implantation, and he never had the need to be re-intubated. Now, could this patient have been weaned off the ventilator eventually after getting a tracheostomy? Absolutely. But I do think that this is a great example of where the pacer facilitates their care. In terms of weaning them off the pacer, he eventually did wean off the pacer and had the electrodes removed in clinic. And it's similar to tracheostomy collar weans, where you initially turn the pacer off for 30 to 40 minutes and slowly increase until they're off the pacer all day, and then you start turning it off at night. We do recommend an overnight pulse ox study to ensure that they're getting adequate ventilation at nighttime. And if you are in Cleveland, then you can get an EMG of the diaphragm. I don't think I'll have that technology out here, but that can kind of show how much recovery of the diaphragm exists. And I think this picture kind of really points to how much the pacer not only helps them get off the ventilator faster, but also helps facilitate the rest of their care. And so this is a picture of a patient with a pacer in his pocket. Instead of being connected to a ventilator and having a machine, he's able to get out of bed and help work with rehab, and it really just accelerates their rehabilitation process. And patients that may not even get off the ventilator 100%, still having a few hours on a pacer makes things, in life more enjoyable, like being able to get in a swimming pool or, go to appointments without having to bring a machine with them that is breathing for them. So I do see that there's a huge quality of life improvement in these patients. So in terms of my practice, I'm a laparoscopically trained surgeon from my fellowship out in Cleveland, and I'm now based in Portland, Oregon, and mostly operate out of Legacy Good Samaritan, which is a 530-bed hospital, so it's not a huge hospital. But I think one of the benefits of practicing here is we actually have the Legacy Rehabilitation Institute of Oregon, or the RIA, which is an inpatient rehabilitation facility with phenomenal 24-hour care, and really some recent high-tech innovations. They have kind of the newest model of zero gravity rehabilitation equipment and things like that. And I do think a lot of the spinal cord injury patients, at least in our area, end up at Rio anyway for rehab. And so it's really nice that I have the ability to be performing diaphragm pacing at the same institution that inpatient rehabilitation is an option. In terms of placing pacers, I did have to get FDA approval or IRB approval to be able to perform diaphragm pacing here at Legacy. So I do have that approval to be performing this procedure for spinal cord injury patients. In terms of the other indications for potential diaphragm pacing, it's kind of a case-by-case basis, and I do have to get an IRB exemption to be performing for off-label uses. In terms of referrals for this, I'm happy to consult about any patient that might be qualified for diaphragm pacing. And you can always just call my office or myself and to discuss patients. And kind of what's going on back in Cleveland, it's been a very interesting year with COVID-19. Dr. Anders has a new device that's the Trans-Aortic Percutaneous System that actually received emergency approval at the start of the pandemic. And the nice part about this is it's actually an implantable device that can be done at the bedside, or it can be done in the operating room, but it's a temporary pacing device. And the goal is to kind of get as many patients off mechanical ventilation as possible, especially at the beginning of the pandemic when we were worried about access to ventilators and having a ventilator shortage. If there were other patients in the hospital that could potentially get off a ventilator by using this percutaneous device, it's a great option. So he's been doing lots of research in cardiac, lung transplant, cardiac transplant patients, and even any patient that's getting evaluated for tracheostomy of whether or not they would benefit from a temporary device to try to get them off a ventilator faster and potentially free up other ventilators for other patients. And so I do think diaphragm pacing is definitely here to stay in the medical community. And I am surprised that I honestly had never heard about it in my 5 years of training and extensive time in trauma facilities here in the Northwest. And so